Hi, this is E. David Crawford from the University of Colorado. Thank you for joining me and our faculty in this program entitled Navigating the Adverse Effects of ADT, Improving Patient Outcomes. I bring you greetings from Colorado. My disclosures are on this slide. I am happy to introduce our faculty. We have an outstanding faculty, including Dr. Thomas E. Keene from Medical College of South Carolina, Neil D. Shore from the Carolina Urological Research Center, and Jonathan H. Pinthus, who is from McMaster University in Ontario, Canada. There's a lot of history in androgen deprivation therapy going back to the 1800s with castration. The first tumor marker in oncology was 1938, acid phosphatase, a Nobel Prize in 1940 for Huggins. Estrogens came along, non-steroidal and steroidal anti-androgens. We had LHRH agonists come along, and Andrew Shalley got a Nobel Prize for that. And then, in the last decade, we've seen a lot of new drugs introduced, including the antagonist Abiraterone and now DeCRLX, and androgen biosynthesis inhibitors, Abiraterone, and really third-generation anti-androgens, Enzalutamide. The side effects of ADTs can be sort of broadly categorized under castration syndrome. Loss of libido, fatigue, hot flashes, intellectual capacity changes, emotional changes, depression, muscular strength, different fat appositions, osteoporosis, and cardiovascular disease. We can also look at them and sort of side effects of conditions like sarcopenia, bone loss, leading to cardiovascular events, osteoporosis, and then further complications including cardiovascular death and fractures, and also skeletal-related events. What do the guidelines say? I chose the European guidelines to look at here, and there is some help, but not really a lot. You can look here and see loss of libido, not a lot you can do for that. Erectile dysfunction, hot flashes, we've been dealing with that for centuries, gynecomastia. A lot of it has to do with health, healthy diet, exercise, things like that. To deal with that. And we'll discuss some of those during this program. One of the questions that you want to ask are all forms of ADT the same? And I would say not. The objectives are many: decrease testosterone, control prostate cancer, reduce cardiovascular events, urinary complications, and musculoskeletal complications. There's no question that cardiovascular complications are a major issue. And one that we will deal with in this symposia. If you look at cardiovascular events, it's the second most common cause of death in men with prostate cancer, and this has been shown in a number of different trials. This is not new. We go back to 1967 in the VA studies, and there was a study with men with radical prostatectomy and orchiectomy with or without estrogens. Clearly, you can see here that there is almost a double the rate of cardiovascular events, including fatal cardiovascular events, in men who are on estrogens. There have been a large number of observational studies that have looked at cardiovascular events, including sudden cardiac death, and there is a variation among these events depending on the type of androgen deprivation therapy that is utilized. The FDA in 2010 issued a warning asking manufacturers of GnRH agonists to add this safety information to the drug labels about the increased risk of diabetes and certain cardiovascular diseases, including heart attack, sudden cardiac death, stroke in men with prostate cancer. If we look at antagonists versus agonists in studies that have been done in the last decade, what we see is there is an apparent difference in a number of these side effects, including cardiovascular. If you look at one study that was done that we will go over, CS 37 with DeCRLX, it showed a difference in death rate between an antagonist and an agonist, and most of the deaths early on were related to cardiovascular, not prostate cancer. Urinary symptoms. We know that half of the men with prostate cancer have moderate to severe urinary symptoms. There is a difference, and we'll discuss those, on how we treat these men with ADT. And we do know that there are studies that have been done comparing antagonist to agonist and looking at things like IPSS score and volume reduction and things like that. And we do know that there is, and again, in some of the studies done with the antagonist, a difference in the rates of urinary tract events in men. We also know that bone loss and musculoskeletal issues are common in men on ADT, and over 58% of men with risk factors for skeletal complications develop at least one fracture within the first 10 to 12 years, and there is a higher mortality associated with that. We look at these musculoskeletal events, again, there's some discrimination and difference between the type of ADT used. So in conclusion, ADT therapy is associated with many side effects, and the most prominent one, and one we're concerned about, are cardiovascular. We'll discuss all of the side effects during this program. We need to monitor these and try to navigate the patient through the issues with cardiovascular and other events.
Good afternoon, everybody. This is Tom Keane from the Medical University of South Carolina. I'm going to be discussing androgen deprivation therapy as it relates to bones and hot flashes, and also its use with chemotherapy and timing. As we look at androgen deprivation therapy in general, there's a lot of sexual dysfunction, which I will just mention, but I should point out that not alone is there sexual dysfunction present with ADT, but there are also a number of other things which you see listed on the slide in front of you. There's significant weight gain, there's gynecomastia, loss of libido, loss of body hair, hot flashes, which you will discuss in more detail. There's also bone alteration, and you can see there's numerous different complications, which some are related to primary therapy, some to androgen deprivation therapy for prostate cancer, and then we have some that are shared with both. Some of these strategies, and there are many, which have been undertaken to mitigate the side effects of ADT, would include intermittent timing of ADT, in other words, stopping and starting, reducing the duration of ADT, anti-androgen monotherapy, and also exercise therapy. Now, intermittent ADT has been shown to result in improved desire for sexual activity compared to continuous ADT. However, this is only a viable option for men with a rising PSA and after local therapy without evidence of metastatic disease. Also, reducing the duration of ADT can result in significant improvement in sexual function and activity when comparing 6 versus 36 months of ADT with high-risk locally advanced prostate cancer. However, there was an increased risk of mortality in the reports which were published, and as such it cannot be really recommended. There is a randomized controlled trial of leuprolide versus bicalutamide, which found less of a decline in sexual interest in anti-androgen monotherapy alone, but this cannot be routinely recommended, as anti-androgen monotherapy is inferior to GnRH agonist therapy. So if we delve a little bit more into the intermittent versus continuous ADT, in 2012, almost 1,400 patients were reported with biochemical recurrence and a PSA of over 3 nanograms per mil 1 year after primary or salvage radiotherapy for localized prostate cancer, and they were randomized to receive intermittent ADT in monthly cycles versus continuous ADT. After a median follow-up of 6.9 years, there was no difference in overall survival, with a median overall survival of 8.8 years in the intermittent group versus 9.1 years in the continuous group. And again, quality of life was assessed at fixed time points, regardless of the phase of treatment. This was a study by Crook et al. From Canada, which was reported in the New England Journal. baseline quality of life scores were similar in the two groups for most items. For functional domains, mainly physical, role, and global health, the intermittent therapy group had scores that were slightly better than those in the continuous therapy group, but the differences were not significant. For items pertaining to symptoms, intermittent therapy was associated with significantly better scores for hot flashes, desires for sexual activity, and urinary symptoms, with a trend towards improvement in the level of fatigue. In a meta-analysis of 15 trials, which is published by Magnan et al., it involves nearly 7,000 patients and was published between 2000 and 2013. These were the papers. No significant difference was seen between intermittent and continuous therapy for overall survival, cancer-specific survival, or progression-free survival. However, there was minimal difference in patient-tolerated quality of life, and as such, even though intermittent androgen deprivation therapy was not inferior to continuous therapy with respect to overall survival, lack of significant improvement in quality of life and symptoms does not merit a change from standard treatment. And finally, in the article from Hussain et al., published in 2013, was a large phase 3 trial of patients with metastatic disease. Survival with intermittent ADT was not comparable to that in patients with continuous therapy. There were over 3,000 patients with a follow-up of 9.8 years, and median survival was 5.8 years for continuous therapy versus 5.1 years for those with intermittent therapy. Subgroup analysis identified that patients with minimal disease had a median survival of 7.1 years for continuous versus 5.2 years for intermittent. Loss of almost 2 years of life in the intermittent group could not be ruled out. Therefore, continuous androgen deprivation was felt to be significantly better in the minimal disease group, with a 23% relative increase in the risk of death with intermittent androgen therapy. So based on that, one would have to say that this significant difference could translate to a 20% relative increased risk of death with intermittent therapy as compared with continuous therapy when you looked at them together. So I think as we look again at intermittent versus continuous, survival is worse in intermittent androgen deprivation therapy for patients with metastatic disease compared to continuous hormonal therapy. The lack of statistically significant inferiority of intermittent androgen deprivation does not equal clinically insignificant differences. And combined data from randomized controlled trials does not support a large or durable effect on quality of life. So if we accept that continuous is more than likely what we're going to need, then how do we address the hot flashes and androgen deprivation therapy? Over 50% of men will complain of hot flashes on ADT, and these and other vasomotor symptoms are due to hormonal withdrawal from decreased testosterone, causing a rapid disruption in estrogen and androgen equilibrium, which impacts the temperature set point in the anterior hypothalamus, causing the peripheral thermoregulatory mechanisms to be activated inappropriately. They occur equally with most forms of ADT except for oral estrogens. Clinicians should recognize the frequency of this side effects and screen all patients regarding these symptoms. In terms of management, what can we do? Well, one of the options is medroxyprogesterone acetate. And after 1 month in this study, and there's a number of studies on this slide, after 1 month, all groups had significant improvement in their hot flashes, with the greatest improvement being shown in the Abiraterone group, which was 94.5%, and the medroxyprogesterone acetate group, which was 83.7%. Because progesterone could interfere with ADT, medroxyprogesterone acetate is the gold standard treatment for ADT-induced hot flashes. What about during the hot flash treatment period? In this trial, there was 201 adverse events occurred, most commonly gastrointestinal disorders, vascular disorders including thrombosis, and hypertension and nervous symptom disorders including headache, anxiety, and memory impairment were identified. Another option is acupuncture, and this is one of the alternative remedies which have been studied. And what we're looking at here is there's a number of prospective studies which report up to an 89 to 95% improvement in hot flashes with acupuncture. The proposed mechanism of action is that acupuncture stimulates release of serotonin, and norepinephrine in the hypothalamic regulatory system, which therefore modulates peripheral the autonomic nervous system. Looking at a randomized controlled trial published by Walker et al. In 2010, they compared 12 weeks of acupuncture versus venlafaxine in breast cancer patients on hormonal therapy with tamoxifen. There were 50 women with breast cancer on hormonal therapy with tamoxifen who were randomized to receive either of these two options. The health outcomes were measured for up to 1 year post-treatment. Both groups exhibited significant decreases in hot flashes, depressive symptoms, and improved quality of life from pre to post-treatment. These changes were similar no matter which treatment you were on. But by 2 weeks post-treatment, the venlafaxine group experienced significant increases in hot flashes, whereas hot flashes in the acupuncture group remained at low levels. The venlafaxine group experienced 18 instances of adverse events, including nausea, dry mouth, dizziness, and anxiety, whereas the acupuncture group experienced no adverse events. So what about ADT and bone health? Well, we know ADT accelerates bone loss in men. We know bone mineral density decreases by 5 to 10% at 1 year and begins within 6 to 9 months of ADT initiation. There's an increased bone turnover, which can result in an increased fracture risk. And there's up to a 21% relative increase in clinical fractures on ADT. The International Society for Clinical Densitometry guidelines recommend utilizing the fracture risk assessment tool released by the World Health Organization to determine fracture risk. For men with a 10-year risk of hip fracture, over 3% based on this tool, a baseline bone mineral density scan should be obtained before initiating ADT, followed by a scan 1 year or after 1 year of therapy for men on long-term ADT. What can we do to prevent this complication? Well, 120 milligrams of calcium and 800 to 1,000 international units of vitamin D have been recommended. No randomized controlled trials have been performed to evaluate whether supplementation improves bone mineral density for patients on ADT. But it is reasonable to make these recommendations. And now currently we may want to go up to 4,000 international units per day, which is actually the level recommended by the Institute of Medicine. There are other agents as well which can be used, which will include bisphosphonates, denosumab, and SERMs. So looking at bisphosphonates, this was randomized controlled trials of bisphosphonates have been shown to increase bone mineral density or reduce bone mineral density loss in men receiving ADT. Most recently, a 2013 study found the addition of weekly oral alidronate improved spinal bone mineral density by 1.7% compared to 1.9% with calcium and vitamin D alone. There was a systematic review and meta-analysis in 2012 of 15 trials, which included over 2,600 subjects who reported that bisphosphonates as a class prevented fractions and osteoporosis with a relative risk of 0.8 and 0.39 respectively. This was data from Netto et al. Published in Prostate Cancer and Prostatic Diseases in 2012. Looking at denosumab, it's a humanized monoclonal antibody against NF-kappa beta. And this cartoon shows you how it works. And it basically blocks maturation of pre-osteoclast to osteoclast and thereby prevents bone reabsorption. Now, as I've mentioned, it has been shown in a randomized controlled trial of 1,468 men to increase lumbar spine bone mineral density at 24 months by 5.6% compared to a 1% in the placebo group in this trial, which was reported by Smith et al. In the New England Journal of Medicine in 2009. Denosumab treatment also led to a decreased incidence of new vertebral fractures at 3 years, and the figures were 1.5% versus 3.9% with a relative risk of 0.38. Looking at SERMs, there are a number of them, and while SERMs such as raloxifene or teremifene have been shown to improve mean bone mineral density and reduce the incidence of new fractures by 50% compared to placebo in men on ADT, there was a statistically increased incidence of venous thromboembolic events with the SERM therapy, and as such, they are not FDA approved for the prevention of ADT-related bone loss. So looking at the NCCN guidelines, for men with a 10-year risk of hip fracture of over 3% based on the FRAX algorithm, the recommendations are what I've given you before, the calcium and the vitamin D, and either denosumab 60 milligrams sub-Q every 6 months, or zoledronic acid 5 milligrams IV annually, or alidronate 70 milligrams PO weekly. The higher doses of denosumab are included for those patients who have significant metastatic disease and usually castrate-resistant disease, although it does tend to be used for men who are also non-castrate by many urologists. So that deals with the bone health recommendations and where the land lies in that area. Next, I would like to move to the chemo part of this talk. And I would start by saying that ADT in the current era needs to be personalized for the specific patient. And there's a number of things which need to be considered, namely cardiac complications, obesity and testosterone, control of FSH, high volume metastatic disease versus low volume, docetaxel and significant LUTS. And all of these are factors which should go into any decision on the use and type of ADT. So let me go back to what has recently been found. We know the testis produces testosterone, and LHRH agonists and antagonists work there. We know the adrenal glands also contribute production, and anti-androgens have worked there. But more recently, we have discovered that prostate tumor cells themselves produce their own testosterone. So we have now 3 sites where we can identify production of testosterone. And these findings have led to the more recent anti-androgens and anti-testosterone agents, one of which is Abiraterone, which I've shown here on this slide. And you can see that it's a CYP17 inhibitor. And there have been a number of trials of it, and typical of the way drugs were developed over the last decade, we started at the very end of the spectrum, namely on patients who were castrate-resistant they had castrate-resistant prostate cancer, they had been through most of the therapies, and they were now post-chemo. And this was the patients who were included in the first trial of Abiraterone, which was Cougar 301. And it was a successful trial showing a significant advantage for this agent. And then, of course, it moved into the pre-chemo area, still in castrate-resistant prostate cancers. And you could see here that there was an equally efficacious outcome in the Cougar 302 trial. The second big agent was the anti-androgen enzalutamide, which is really a third-generation anti-androgen with 3 separate mechanisms of action. It was FDA approved in 2014, and the indications are in metastatic castrate-resistant prostate cancer with recurrence, or metastasis. And again, there was a post-chemo or docetaxel trial first. Then there was a pre-docetaxel trial, which was the Prevail trial. And more recently, there's been the Strive trial where they compared it versus bicalutamide in men with castrate-resistant prostate cancer. The Prevail trial was recently published again, or there was an extended analysis of this published, and there was a reduced risk of radiographic progression by 68%, or of death by 23%. There was radiographic progression-free survival at 20 months versus 5.4 months for placebo. And there was an improved median overall survival. It was 35.3 for the treated patients versus 31.3 for placebo. There was also an evaluation of the longer-term efficacy and safety up to the pre-specified number of deaths in the final analysis. And as I mentioned, 20 months for the radiologic progression-free survival, 9 months for overall survival, and 4 months for safety. Adverse events included back pain, constipation, fatigue, and arthralgia. And then recently the Strive trial, which was just announced also within the last year. This was enzalutamide versus bicalutamide in men with prostate cancer progressing on ADT, 198 patients in each arm. PSA progression-free survival overall was 19 months for the enzalutamide versus 5.7 months, which was highly significant. And there were highly significant findings in favor of enzalutamide in terms of time to PSA progression, the percentage PSA response, the duration of radiographic progression-free survival, and the best overall soft tissue response. Exactly what one would have expected. This slide shows how the landscape in prostate cancer has changed since 2010. You can see it listed here. And along with new drugs has come new concepts. And one new concept is the question of should these advantages be applied to hormone-sensitive prostate cancer patients? And if so, which agents and when? So in order to look at this final part of this talk, we're going to have a talk about the CHAARTED data. We're going to look at the CHAARTED study, E3805. We're going to do a comparison with the GETUG-15 study. And then we're going to ask the question of who really should receive docetaxel. Should it be the high versus the low risk groups? And we'll have a look at some safety and toxicity considerations. Looking at the CHAARTED data, we all know this data. It was presented by Sweeney at ASCO 2014. There's been a number of publications on it. And patients were stratified into extent of metastatic disease, age, performance status, CAB greater than 30 days, skeletal-related events prevention, and prior adjuvant ADT. And the randomization was to ADT plus docetaxel versus ADT alone. And the findings were really a major surprise for the urologic community when it showed that there was a significant survival advantage for those patients receiving ADT plus chemotherapy up front. It was a 790-man trial. There was a planned interim analysis at 53% of patients who met information. And in the January of 2014, there was a median follow-up of 29 months. There was 136 deaths, 110 with high volume disease for ADT, compared to 101 deaths, 82 high volume deaths with ADT plus docetaxel. So a significant advantage for the ADT plus docetaxel. And 83.6 versus 83.2 of the deaths were from prostate cancer. While overall survival was assessed in the subgroups of high and low volume, the benefit of this early analysis is more apparent in the high volume subgroup. Specifically, in patients with high volume disease, there's a 17-month improvement in median overall survival, with an increase from 32 months with ADT alone to 49.2 months with ADT plus docetaxel. Note that the survival curve split very early in the high volume group. In the low volume metastatic group, the hazard ratio were similar, but the curves don't start to split until much later, closer to 2 years. So this data is probably not mature enough. So if we look then at the GETUG study, and that basically really brings up a first question. We have this great randomized controlled trial from France and Belgium, which looked at the same thing, but it was negative. It did not show the same survival advantage. And the question that we have to ask is why? So if we look at some of the key differences between the GETUG and the CHAARTED data, this is a busy slide, but you see that there was more statistical power for the CHAARTED study. The Gleason grades are interesting. They're missing data on 1.8% in the GETUG versus 11.4% in CHAARTED. So known data may look worse. PSA data was clearly higher in the CHAARTED patients. The definitions for high volume or poor risk are different in the trials, and that is a fact that that needs to be considered in the design of all trials. Toxicity seems to be higher for the GETUG patients. The point being is are there more people who didn't receive full chemotherapy dosing, and could that have contributed to worse outcomes in GETUG than in the chemo arm? There's a shorter follow-up in the CHAARTED data. And the subsequent docetaxel story, we will focus on only those that progress to castrate-resistant prostate cancer. So you can see that, and we also see that subsequent treatments after failure may be different between these two groups. So the summary of factors that may have contributed to different results between the GETOG and the CHAARTED would include study size and statistical power, prognosis and staging definitions and disease risk and volumes were different, and the toxicity, particularly the toxicity when you look at the deaths and the early discontinuation and the use of other subsequent therapies, these were different. So there's been some controversy in the field over whether giving docetaxel in the hormone-sensitive prostate cancer setting might be less toxic since it is earlier. But then again, maybe it's more toxic, and the publications with GETOG seem to imply that. But if you look at TAX 327 and GETOG and CHAARTED, which we shouldn't really do, but let's have a look at it anyway, there's a difference in the neutropenia, and neutropenia itself doesn't have major clinical implications. But when you look at febrile neutropenia, it is important, and it was higher in the hormone-sensitive prostate cancer trials than in the TAX 327 trial. We have to also remember that GETOG didn't allow the use of growth factors at the start of the study, and there was over 56% of the study had been accrued before it was brought in. There were 4 treatment deaths, and the Disease Safety Monitoring Committee recommended that GCSF should be used with declines in grade 3 to, and that resulted in declines in grade 3 to 4 neutropenia and also febrile neutropenia, and there were no more deaths. But the key conclusion is more a question than anything else, and that is, since there are earlier patients, why might we see more toxicity? What is the reason for that? And we see it here. And this was basically a study which was published. There's actually 2 studies published, which dealt with docetaxel in the castrate and in the non-castrate setting. And in one of the studies, there were 10 non-castrate and 20 castrate men with similar demographics. And clearance of docetaxel in the castrate men was 100% increased, with a 2-fold reduction in the area under the curve. The authors performed the erythromycin breadth test, which indicated hepatic CYP3A4 activity for docetaxel metabolism was not different. So basically what this transpires to mean is that there is much more of the docetaxel which is kicked out of the liver in the castrate patients than there is in the non-castrate patients. And a 50% decrease in docetaxel clearance has been associated with an over 430% increase in the odds of grade 3 to 4 neutropenia. So what are the implications of these PK differences? Well, it may explain some of the differences between the trials, may explain some of the greater hematologic toxicity, but also some of the survival benefit observed in castration-sensitive compared to castrate-resistant trials. Why was there greater hematologic toxicity in the GETOG versus the CHAARTED study? Well, one of the questions that need to be asked is how many patients were non-castrate versus castrate in each trial. And in the GETOG study, 47% of the initiated patients initiated ADT within 15 days of enrollment. In the CHAARTED study, the patients initiated ADT at a median of 1.1 months after enrollment. So that would tell you that there is a difference in the patients who were castrate versus who weren't. Now, the recommendations are for the practicing clinician, they should consider waiting until 1 to 2 months after ADT or castrate testosterone levels have been reached before starting docetaxel. That makes sense because the toxicity is less. And they should consider using GCSF at least for the first couple of cycles until the patients are castrate. But maybe we should also consider and ask the question that if the toxicity is greater, might not the efficacy be greater? And I did show this, I want to show this slide, the Stampede, which was the 3rd study to be published within a short period, showing the benefit, or looking at the benefit of early ADT plus chemo in the non-castrate patients. And you can see here that it supported the findings of the CHAARTED data. So I go back to the question that I just asked, and you see it here. How do we answer this question? If toxicity is greater with the use of docetaxel in the pre-castrate state, might not efficacy also be? And the answer is simply, we need a trial. And this is the trial which is currently enrolling. It is a phase 2 trial. It's only enrolling 50 patients. And we're enrolling men with newly diagnosed treatment-naive metastatic prostate cancer of all volume status. The primary endpoint is the proportion of men who maintain a PSA of less than or equal to 0.2 at 40 weeks on study. That's after 7 months of ADT. We will also look at a number of additional endpoints which are listed here. So finally, these are perhaps some considerations for the use of ADT. And I really want to focus at the very end of this slide that I have. And that's for patients with metastatic hormone-sensitive prostate cancer who are going on chemo and ADT. What would be the best way to give it? Well, if you want your patient to be castrated in very quickly after giving, say, 3 or 4 cycles of docetaxel, then the best way to do it is with an antagonist, because your patient will be castrated within 48 hours. And if you're not doing it, then I think the options lie when people ask, should you use an agonist versus an antagonist? It very much depends on whether the patient has a pre-existing cardiac disease, whether the patient has higher volume metastatic disease, because both of these in the past and in a limited number of studies have shown benefit in favor of the antagonist. Thank you.
Hello, I'm Neil Shore. I'm the Medical Director of Carolina Urologic Research Center. I'm pleased to offer this presentation on navigating the adverse effects of androgen deprivation therapy, improving patient outcomes, and to specifically address some of the less widely discussed side effects, the perception versus evidence of the data. We'll hear other presentations on cardiovascular side effects and bone demineralization side effects, as well as hot flush and loss of libido. There are multiple common adverse effects of androgen deprivation therapy, which are outlined here. And I would like to address today some of the questioning ways to deal with these adverse consequences. Specifically, my presentation will review the issues of glycemic dysfunction, insulin resistance, also talk about issues regarding cognitive impairment, possibilities of some reports regarding dementia and fatigue as well. There are multiple off-target effects of testosterone deprivation strategies. Testosterone has numerous effects throughout all different organs within the body. We are clearly aware of our known reasoning for providing a therapy to diminish eugonadal levels of testosterone in order to create a level of prostate cancer, adenocarcinoma regression, or stabilization of disease. But unfortunately, there are adverse events that can occur, and the target organs are well described here. When one institutes androgen deprivation therapy, one can oftentimes have conversations with patients and their caregivers to understand what are the effects besides seeing PSA declines, regression radiographically of disease, or improvement in obstructive urinary symptoms. There is a price to be paid, and there's a constellation of symptoms and conditions. And so we're also seeing now that ADT, in addition to its well-described use from the days of Hodges and Huggins, that it was primarily found to be a hormone-sensitive disease for metastatic lesions. We're seeing the use of ADT strategies very commonly in men with non-metastatic disease, so a longer time frame to be exposed to the off-target effects. So ADT causes a variety of many effects, and I've alluded to them already. And here, this slide demonstrates some of the buckets of adverse event and toxicity. And of course, as we have entered the era of patient-physician shared decision-making, we also need to be better stewards of understanding the impact on the different off-target organ systems, whether it's the central nervous system, myeloproliferative function, sexual function, musculoskeletal effects, and of course, the endocrine pathway. In addition to lowering T, what effects are happening on both lipid and metabolism and insulin resistance. So there have been well-described changes in the metabolic effects of ADT. The metabolic syndrome, which encompasses many different disease entities, is a disorder of energy utilization and storage described by the co-occurrence of any of the three listed developments. So central abdominal obesity, hypertension, an elevated fasting plasma glucose, elevation of serum triglycerides, and a lowering of high-density lipoprotein cholesterol levels. Other presentations in this program will very in-depth look at the risks of cardiovascular disease. So let's proceed. Looking at a table of the metabolic syndromes which occur in the classic form of metabolic syndrome versus what we see with institution of ADT. Yes, we see triglyceride elevation. We see an increase in subcutaneous as well as visceral fat. Interestingly, and for no clear discernible reason, the good HDL increases in many trials looking for patients on ADT versus it being reduced in the metabolic classic syndrome. Hypertension occurs in both syndromes, whether associated with ADT use or not. An increase in fasting glucose and insulin resistance, an increase in adiponectin, which can affect both visceral and subcutaneous fat levels, as well as a normalization of C-reactive protein, which may have cardiovascular implications with ADT use, but not with traditional metabolic syndromes, which see an increase in CRP. And so here's a nice example of a eugonadal CT scan of a young man versus a man who has experienced excessive ADT. One sees the increase in adiposity both viscerally and in the subcutaneous space. And all of us who've treated men for long periods of time in our careers with prolonged use of ADT will see central abdominal weight gain and oftentimes the associated gynecomastia. GnRH agonists can significantly increase serum lipid levels, and this was very well described at the turn of the century by Matthew Smith, demonstrating elevations in cholesterol, the less attractive forms of cholesterol, LDL, and triglycerides, but interestingly, an elevation of HDL, and these were all found to be statistically significant. Subsequently, Smith and others additionally published that there is an increase in insulin resistance or reduced sensitivity in men undergoing androgen deprivation strategies with the form of GnRH agonists. So the relationship was further well described and published by Keating et al. And the Journal of Clinical Oncology, that looking at various forms of androgen deprivation therapy, primarily the GnRH agonists, as well as with orchiectomy, that the hazard ratio was rather significantly increased, a much higher likelihood, as one can see here, that was statistically significant for an increase in developing both level 1, level 2 evidence for diabetes. And this was also found in subsequent papers by both Keating and Alabahi, that there was consistency amongst population-based studies, both looking at large cohorts of SEER Medicare claims-based data, a large cohort in Canada, the Ontario Registry, and another very large cohort of the Veterans Administration review, that the hazard ratio was consistently demonstrating with the use of androgen deprivation therapy the association with a very high concordance of diabetes. So the association between androgen deprivation and diabetes is found to be plausible, and it appears to be related to a decrease in insulin sensitivity. And this has both baseline and downstream implications in how we can better counsel our patients. And there have been recommendations that have been proposed by many. Here's a reference from Saylor et al. In this Journal of General Internal Medicine, that one should consider testing all men initiating on ADT with a hemoglobin A1C, and that there should be further evaluation for monitoring and dietary and or additional medications, whether they be oral or insulin-based, based upon the level of the hemoglobin A1C. And there can be other attempts to treat cardiovascular risk factors, that testing should be repeated, lifestyle interventions regarding low carbohydrate diet, as well as the importance of some form of physical activity, typically combining aerobic and resistance training. Now, regarding multiple studies that have looked at the association of fatigue, gynecomastia, and sexual dysfunction, I'll just touch for a minute on the numerous randomized controlled trials which have demonstrated that there is an obvious correlation with level 1 evidence for gynecomastia. Here is a mention of a strategy which is rather aggressive to use radiation therapy and aromatase inhibitors versus also strategies on trying to preclude sexual dysfunction, which we'll talk a little bit more about regarding intermittent use of ADT and additional exercise training. Regarding fatigue, there's no doubt that lowering eugonadal levels of T results in significant fatigue to many, many patients. It's been well demonstrated, and certainly a wide-held empiric evaluation amongst specialists who use ADT for prostate cancer patients. Aerobic and resistance exercise has been demonstrated in several studies to help mitigate, or in some patients even negate, the development of debilitating quality of life, fatigue, and lack of exercise tolerance. Now, as it relates to some papers that have been published recently, here's the one by Need et al. in JCO in 2016, and they reported looking at two institutions, Mount Sinai Hospital and Stanford Hospital, and clinics, approximately 5 million patients, but a subset of patients who actually had a diagnosis of prostate cancer, totaling approximately 17,000 patients, or a little over 18,000 in an available cohort. And essentially what they did was they saw that there was an additional 125 of all of these patients with a new diagnosis of Alzheimer's disease. What was interesting regarding this is, and they note this in one of the limitations of their discussion, was the potential for misclassification as it was related to claims-based data. They went on to also demonstrate in their own reports that there was quite a significant degree of the baseline demographics of the full cohort. Looking at the patients who were ADT users versus those who were not, there were significant statistically notable differences in the age of patients, the racial makeup, who smoked or who did not, use of antiplatelet medication, anticoagulant medication, and antihypertensive medication, which could, of course, have implications on cerebral vascular blood flow. Statin use of note was not statistically different, and even cardiovascular disease at baseline was different within, and the presence of diabetes was different and higher in the patients who were started on ADT. So I think that there is certainly some concern here that in their conclusions that there was a causology, but in reality there appears to be a very significant need for additional prospective data for their conclusions, of such a small cohort of patients diagnosed and the disparities in the baseline demographics. This Kaplan-Meier curve also speaks to the relatively short median follow-up of 2.7 years. So there's a lack of specificity to suggest that there really is not a causal link between ADT and dementia, but to the credit of the investigators, additional prospective trials should be conducted. And here's additional work done by Kavar, and this was looking at another larger group of patients. And looking at this forest plot, one does not see that the risk of dementia for patients on ADT, regardless of their time frame evaluated, regardless of the use of other neuro medications such as antipsychotics and or the use of chemotherapy, which may have downstream effects on neurocognitive function, but neither of these are, and in this forest plot, has any significant effect on the risk for dementia and concomitant ADT use. So the conclusion also of Alabahi and again in JCO, looking at a large UK and Canadian-based claimed data showed that there was no consistent evidence that 12 months of ADT had an adverse effect on cognitive function. This group was not looking at Alzheimer or dementia diagnoses, but actually in cognitive function. And they used some questionnaires in a control group, in a group that was to receive the ADT, a group that did not, as well as healthy controls. But that said, you know, there are different domains that one needs to interrogate to look at cognitive function. And once again, there is an importance to recommending strategies to avoid deterioration of any form of cognitive function in the elderly and certainly those who undergo an ADT therapy. And thereby we tend to use sometimes an intermittent androgen deprivation therapy to cut down on the duration of therapy and thus potentially minimize adverse effects, improve quality of life, but the concern being the delay in prostate cancer disease progression, and there have been various arguments regarding CRPC progression versus not, and there's a certain trade-off both on off-target adverse events and even at some point thinking about the cost considerations and a global consideration. So in conclusion, ADT causes some certain well-known specific harms: hot flashes, fatigue, anemia, sexual dysfunction, muscle wasting, central abdominal weight gain, bone demineralization, and the associated greater risks of fracture and diabetes. Previous presentations in this program will address risk mitigating strategies, as I have addressed today with diabetes. Not all harms are always associated with ADT are causal, and so there is still controversy regarding cardiovascular disease, dementia, colorectal cancer, and others which we have not had the full time to review. When considering the harms linked to ADT, one has to look at the advantages for instituting the therapy, and one has to look at some of the biological plausibility that is associated with the adverse effects. But again, it's a trade-off in diminishing and slowing down prostate cancer disease progression. Thank you very much.
I believe the pertinent questions with respect to my topic is A, is ADT actually promoting cardiovascular disease? If so, why ADT may promote cardiovascular disease, and what can we do about it? It's very important to mention that the prostate cancer patients are actually at high risk of cardiovascular disease. The American Heart Association considers a 20% 10-year risk of coronary artery disease to be high. Patients with prostate cancer are therefore at high risk for cardiovascular disease because the risk of MI, stroke, or cardiovascular death is calculated as more than 2% per year, and this has been recorded by numerous studies, which I will show. the risk of MI, stroke, or cardiovascular disease in prostate cancer men on ADT is even more doubled as per observational trial, and it's more than 4% per year. So therefore, cardiovascular disease is very prominent in prostate cancer patients. As you can see, this is an observational population-based study that showing by Keating et al. For patients with local regional prostate cancer. This is more than 37,000 patients. You can see that the risk of cardiovascular disease or cardiovascular event is more than 2% in patients with no ADT. And when you go on hormonal manipulations, LHRH agonist, orchiectomy, combined androgen blockade, and even oral anti-androgens, this exceeded and increased. This increased risk has been recorded numerous times, and this is just an example for a meta-analysis of 6 population-based observational studies that included over 119 ADT recipients and over 150,000 ADT non-recipients, and this demonstrated a hazard ratio for cardiovascular mortality of 1.17 among the ADT recipients. So this is for cardiovascular mortality. But we have to bear in mind that the existing observational evidence linking ADT use with cardiovascular disease compromise largely data from administrative databases, which are limited in the covariates recorded related to cardiovascular risk factors. And indeed, the findings from these observational studies contrast with an earlier meta-analysis of randomized trials of ADT, which demonstrated no access cardiovascular deaths in the ADT arm in over 4,000 participants who experienced more than 500 cardiovascular deaths. In fact, in this meta-analysis, ADT exhibited a relative risk of cardiovascular death of 0.93 as compared with control. While this evidence from this study suggests that excess cardiovascular mortality among ADT recipients is unlikely, the randomized trial have limitations with respect to this outcome. Among the 8 randomized trials of ADT, 4 featured control arms that received ADT in a deferred manner, which may have diluted any adverse cardiovascular effects of ADT. Cardiovascular outcomes were not well characterized in the randomized ADT trials, and ascertainments of adverse cardiovascular events may not have been systemic. Therefore, this could reduce the power of these trials to detect the effect of ADT on cardiovascular event incidence. Now, owing to the tendency to recruit men who are otherwise healthy into randomized clinical trial, men with greater comorbidity, including cardiovascular disease, may have been excluded from this trial. And indeed, the largest burden of cardiovascular deaths we know in men with prostate cancer is seen in those with greater comorbidity. So for these reasons, there remains uncertainty, I believe, about the role, if any, that is attributable to the ADT in promoting cardiovascular disease. So, is ADT promoting cardiovascular disease? We are investigating that in the Radical PC trial, which is actually 2 prospective trials, one nested within the other one. The first one is the role of androgen deprivation therapy in cardiovascular disease, a longitudinal prostate cancer study, the Radical PC1, which is a prospective cohort study of men with newly diagnosed prostate cancer and men commencing on ADT. And we have now more than 720 patients. This is an analysis of about 600 of them, the first 600 or so. And you can see, as expected, men that are commencing on ADT have more prevalence of metastatic disease. But what's interesting and very important is that these men, the men who are commencing on ADT for either an indication as for metastatic disease or men with high-risk prostate cancer that are about to start radiation and ADT, you can see that these men statistically have higher prevalence of cardiovascular risk factors and established cardiovascular disease. So here, for example, for coronary disease, there is a double risk, if you will, or a double prevalence of 25% in those commencing on ADT compared to those who are not. And all of these risk factors are marked here in red. In green, you can see that they also statistically significant more chance for the men who are commencing on ADT to be already on cardiovascular prevention strategies and medications such as statins and antiplatelets. So is ADT promoting cardiovascular disease? I believe this question may not be answered because in men who have the indication, on those men we are about to start ADT, we have more baseline cardiovascular disease characteristics to start with, and they're probably more prevalent to be on cardiovascular prevention strategies. So therefore, I believe it's more so comparing oranges to apples. So the model, if you will, is that a prostate cancer patient with high-risk disease, those specific patients who are about to start ADT for either a metastatic disease or for high-risk prostate cancer or intermediate-risk prostate cancer with ADT and radiation therapy, those men have high prevalence of cardiovascular risk factors such as a higher age, obesity, hypercholesterolemia, pre-existing cardiovascular disease or coronary artery disease, and hypertension. And essentially, it may be that the application of ADT is just the stroke that breaks the camel hump and brings the cardiovascular event. So how do we manage that? One can suggest that we'll use a more cardio-friendly ADT modalities, and I will elaborate on that, or we may use some primary prevention to reduce the risk of developing cardiovascular event with ADT. How might ADT accelerate cardiovascular disease? Well, this is a two-way model. Obviously, we know that cardiovascular risk factors such as the metabolic syndrome, dyslipidemia, central obesity, dysglycemia can all be attenuated by ADT, and ADT can promote their development. And this would induce coronary artery disease. But the interesting thing is that once you have coronary artery disease, it may be possible that ADT would induce plaque vulnerability, i.e. cause stable atherosclerotic plaque to rupture and cause a cardiovascular event. And my group believes that this is at least partially can be partially explained by a disbalance between testosterone and FSH, namely a hormonal profile of castrated level of testosterone with elevated levels of FSH. And we have shown that in a mouse model of LDL receptor knockout mice, we could show that ADT does induce the metabolic syndrome. It clearly induces obesity that can be measured by a CT scan, as you can see here, or by changes in leptin levels and dysfunctional fat. It can also induce a glucose intolerance. But most importantly to our topic, it induces atherosclerotic plaques. And you can see here in the gray bars that all modes of ADT, i.e. orchiectomy, leuprolide or GnRH agonist, and the GnRH or GnRH antagonist do induce a significantly larger atherosclerotic plaques in these mice. However, one can see in the white bars that the amount of necrotic core, which signifies a vulnerable plaque to rupture, is significantly lower with the GnRH compared to the leuprolide and to orchiectomy, and in fact it's not different than that in control. And this is very important because the necrotic core is a marker, or if you will, a phenomenon of plaques that are vulnerable to rupture. And when the established plaques are ruptured, then a thrombus comes by, the entire lumen of the artery is occluded, and one gets MI, cerebrovascular incidents or stroke. And we have established both in the mouse model, and it has been shown also in the CS21 extension study, that the use of the GnRH is associated with significantly inhibited levels of FSH. And this also applies to the functional biological function of FSH, and you can see that in the mice that we have studied, the lower levels of FSH were associated with reduced weight of the testicles or reduced volume of the testicle, which is a classic phenomenon of FSH activity. So FSH is significantly inhibited with the GnRH, mildly inhibited with Duprolide, and increased with ochiectomy. Now, the FSH receptor is expressed in the atherosclerotic plaque. We've shown it here to be expressed in the macrophages within the plaque, and those are very important component of the dynamics within the atherosclerotic plaque, because they are the main cause of or have a central role in plaque vulnerability. Those macrophages also accumulate fat and causes the atheroma, and we could show that indeed if you treat those macrophages with FSH, they tend to accumulate more fat and therefore tend to be more dangerous in terms of their ability to release tissue factor and cause the plaque rupture and thrombus. So, is there any evidence, clinical evidence, for a superiority of the GnRH in terms of cardiovascular event occurrence in patients commencing on ADT? This is, we have some retrospective analysis of pooled analysis from clinical trials, prospective clinical trials of about 2,300 patients, randomized in 6 different trials, 2-to-1 to receive either the GnRH or LHRH agonist. This has been done by Albertson et al. And those 2 groups had similar cardiovascular risk profile, but nevertheless, one could see that within a year, there was a 44% reduction in the risk of cardiovascular event or death with the GnRH compared to Luprolide. Now, this is a post hoc analysis of a retrospective analysis of prospective trials that were not meant to test cardiovascular outcome, but rather a clinical efficacy and oncological efficacy of the GnRH. In this AUA, we do present here an abstract looking at a pilot prospective randomized trial between agonist and antagonist. This trial has been led by Professor David Margel from Rabin Medical Center, Tel Aviv University, and what it shows that 66 patients with pre-existing cardiovascular disease were randomized 1-to-1 to receive either GnRH antagonist or agonist. A cardiovascular event was considered to be one of the following: MI, ischemic or hemorrhagic CVA, arterial or embolic or thrombotic event, also some soft endpoints such as emergency room visit or hospitalization due to ischemic heart disease, and revascularization. The median follow-up is currently 8.5 months, and what you can clearly see is that agonists had 30% chance of patients on agonists had 30% chance of developing a cardiovascular event compared to 6% only in patients who were treated with antagonists. Most of these events were including emergency hospitalization for these events, as you can see here. And those were real events. We can see here that if we, the analysis that we did for the levels of NT-proBNP, this is a very good marker for cardiovascular, future cardiovascular events. And this, we could show that if we measured the NT-proBNP before these patients were randomized to receive their ADT modality, i.e. baseline, this could predict future events. And this has been shown by other studies, such as a study that showed that preoperative BNP or NT-proBNP can predict very clearly hard endpoint cardiovascular outcome 30 days after surgery. So this is a very good marker. Now, the interesting thing is this here is this analysis where we analyze the change in FSH levels at 3 months from baseline for each patient. And what's very interesting, and this you can see it here in this waterfall plot, is that 47% of the patients who had decrease of less than 60% in their serum FSH levels within 3 months, i.e. 3 months from baseline, had an event, 47%, compared to only 7% event rate in patients who had more than 60% inhibition in their FSH level within 3 months, and this was highly statistically significant. Now, within the agonist arm, patients with lower than 40% inhibition of FSH are twice much likely to experience a cardiovascular event, 28% versus 57%. So we do believe that FSH, there is a signal at least, that FSH level or the change in FSH level is associated with the development of cardiovascular event once patients is castrated, and of note, all patients in this study achieve castrated level of testosterone. So prostate cancer patients needing ADT have higher baseline cardiovascular disease characteristics and risk factors, and we know that from the analysis of the radical PC patient data up to now. The question, therefore, may not be as much as whether ADT promotes cardiovascular disease, but rather how can we prevent it in this patient population? And there are two options: either using GnRH antagonists or other FSH inhibitors, as we do have, I believe, signals to show that this may be associated with less development of cardiovascular events, or perhaps without usage of routine primary and secondary cardiovascular prevention. Now, the treatment strategies for cardiovascular disease primary prevention is associated with, is well established from multiple prospective randomized trials. And we do that with the usage of aspirin, cholesterol-lowering agents such as statins, and blood pressure control, even at values that are seen to be normal. And this is with ACE inhibitors or other blood-lowering medications. It also associated with lifestyle changes such as diet, exercise, and non-smoking. And a number of health strategies have been shown to reduce adverse cardiovascular outcome in the general population in primary prevention setting. And this, as I mentioned, includes the use of aspirin, statins, and ACE inhibitors among those with at high risk of cardiovascular event. And I would argue that prostate cancer patients are having high risk of cardiovascular event, particularly those who are commencing on ADT. This is just one example for that. This is over 10,000 hypertensive patients with other cardiovascular risk factors, but with no dyslipidemia that were randomized to receive atorvastatin 10 milligrams or placebo. And this is an old trial, a prospective trial in Lancet that showed a clear benefit of 36% reduction of risk of cardiovascular event in this patient population, and this is already within a year. So could we reduce the risk of cardiovascular event in patients commencing on ADT? And we saw from the Albertson data that events are often happening within the first year. So for that, we are conducting the Radical PC2 trial, and this trial is aimed to determine whether systemic cardiovascular and lifestyle risk factor modification strategies reduce the risk of cardiovascular disease in men with a new diagnosis of prostate cancer or men who are commencing on ADT. This trial is nested within the Radical PC trial, and I will not go over the details for the sake of time. Just to mention that patients are eligible for the Radical PC2 if they do not see a cardiologist every year, and if they are not taking all of the following: aspirin, statin, ACE inhibitors, or exercise more than 4 times a week. The intervention in Radical PC, this is they are randomized to in an open manner to either standard care or for intervention, including the usage of aspirin, statin, ACE inhibitors for blood pressure of over 130 or over 80. They receive dietary counseling, exercise advice, and support to quit smoking. This is quite a busy schedule, but we do assess them for many parameters, including frailty and others, as well as obviously cardiovascular endpoints. And the outcome is a composite of primary efficacy outcome: cardiovascular death, myocardial infarction, stroke, heart failure, or arterial revascularization. And I believe that this trial, which is well going, we have more than 700 120 patients up to now, and more sites are joining. I believe this would allow us to understand whether systemic cardiovascular lifestyle risk factor modification strategies reduce the risk of cardiovascular disease in men with newly diagnosed prostate cancer, but more important, if that also help in reducing the cardiovascular event in men commencing on ADT. And the question is, does systemic cardiovascular and lifestyle risk factor modification strategy does add any benefit for patients who are on specific ADT modality? We do not know yet what is the relative risk reduction in patients on GnRH agonist compared to patients on GnRH antagonist, but more so, we don't know if that is also can be further reduced by cardiovascular prevention strategies. It may be that patients on with commencing on ADT with LHRH agonist don't have more cardiovascular events if they are on cardiovascular prevention strategies, or it may be that even with that, the GnRH have more protective effects. You have to stay tuned for results from Radical PC2 to be coming, and I hope it will come sooner than we think, and it all depends on recruitment, which is commencing quite well right now. Lastly, I would like to thank the following people who are with me and helping me. This study could not have been done without them. Dr. Daryl Leong, a cardiologist from McMaster University, who is my co-PI on the Radical PC trial. Dr. Helga Duven-Worden, who is working with me in the lab and is responsible for the mice data that you saw, and Dr. David Margell, who is a colleague, a friend, who conducted the pilot prospective randomized trial of agonist versus antagonist. Finally, I'd like to also thank Prostate Cancer Canada and the Movember Foundation for funding our Radical PC trial. Thank you.